Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and MedTalks, I welcome you all to yet another episode of Diabetes Essentials with Dr. Sanjay Kalra. Doctors, that as you know, that currently that we are having a series of tropical fever, as the July to October month are high fever OPD months. So hence that we are having currently that tropical fever uh, episodes. So that today's topic is fever of 3 days duration. And Diabetes Essential is brought to you by your zero calorie electrolyte drink in the Zal Zero. Now, before moving forward, I would like to announce the last week winners. Dr. Kaval Saluja, Mumbai, Dr. Rajiv Handa from Delhi, Dr. Vinay Desai from Thane, Dr. Bharat Praveen Mitakota from Surat, Dr. Girish Kisota from Mumbai, Dr. Nakul Bansar Panchukula, Dr. Satyanarayana from Hyderabad, Dr. Araz Nizamuddin Khan from Mumbai, Dr. Ashkumar from Kanpur, Dr. Lakshmipati Bhupati from Vellore, Dr. Ramesh Hegde from Bangalore, Dr. Aishwarya Gupta from Gwalior, Dr. Anand Purande from Mumbai, Dr. Yashwant Samant from Mehsal, Dr. Surjit Kalsi from Noida, Dr. Ravi Bhatt from Sirsi, Dr. Satish Kumar Jain from Bangalore, Dr. Shashikant Shende from Mumbai, Dr. Sanjeev Puri from Hoshiarpur, Dr. Shantanu Kumar Bhattacharya from Kolkata. Thank you so much, all the doctors, to take part in our quiz. Now to enlighten us regarding today's topic, I would like to welcome our host, Dr. Sanjay Kalra, President, South Asian Federation of Endocrine Society. Over to you, sir.
Thank you, Ankur, and good evening, everybody. We're all logged in today again on Diabetes Essentials. For the past 1.5 months, we've been talking about tropical fevers. And these discussions on tropical fevers have actually generated a lot of heat. They're hot topics. When we started this series, the idea was Mr. Anang Basu's. We never realized that there would be so much interest, so many questions in this. That's why we are continuing. We have 4 more topics to go on fever. And for today, we have our most favorite, our familiar friend with us, our expert, Dr. Suneet Verma. Warm welcome, Dr. Suneet.
Yes. Thank you, sir. Thank you so much for the introduction and welcome. It's always been a pleasure and to be with you, to listen to you, and to be associated with you. And as sir is saying that we are seeing for last a couple of weeks, we are presenting this, discussing about this fever thing. And that is the need of today. Basically, we can see that there are so many cases in our OPD which are coming with febrile illnesses. I had presented a cases of acute tropical fever or some discussion about acute tropical fever a couple of weeks ago on 8th of last month. And in continuation of that, now today we're going to discuss something different. That is like acute tropical fever with only 3 days of duration. Like patient is coming to us with a fever duration of within 3 days of febrile illness. I'm not saying a fever duration of maybe 2 weeks, 3 weeks, or maybe 10 days, 15 days. Patient is coming to us within 3 days. Now, what to see in those patients? How do we see? Uh, just forgive me. Probably, I think I need to share the slide. Let me check. I think the slide is. Something is wrong. Forgive me. There's something is wrong with the. Just a second. Backstage, could you please help me remove the slides now, please? I need to share my slides again.
Yeah, it's removed, sir.
Just a second, please.
Sure.
So just to keep the things going on till the slides are uploaded, we all know that febrile illness, patient is coming to us, maybe, Dr. Saab, I am having fever for last 2 days, high-grade fever, 103, 104-degree fever. So this is most common cases in OPDs these days. So now, how to approach these kind of patients who are coming to us with this febrile illness? Yes, thank you. Yeah, this one. So, as we all know, what is fever? Fever is elevated body temperature that occurs when body thermostat is reset to higher temperature. Like the thermostat of our human body is set somewhere between somewhere around 98 degrees, 98.4, 98.5, 98.6, or somewhere around 98. But if this thermostat is set to higher degrees, then body stop recognizing that this temperature, which is being raised by body, is abnormal, maybe 100 degree, 101 degree, 104 degrees. Then we have a typical chills. We have a shivering activity that raises body temperature to match that thermostat setting. That's why we have a fever. And why this thermostat system is deranged? This is because of some sort of chemokines, some sort of cytokines. So these cytokines are being released by either infectious illness, maybe neoplastic, maybe some sort of inflammatory illnesses. So the most common cause of acute presentation of fever, like maybe 1-2 days duration, 3 days duration, is infectious illnesses in our setting. And the most common infection is what we call as normal, we call a viral illness, like upper respiratory tract infections, lower respiratory tract infections, maybe UTI, maybe GI infections, gastroenteritis, enteric fever, or maybe some sort of skin infections. So these are the most common cause of acute presentation of fever. So we're going to discuss more about these cases. So what are the important signs to look for? If patient is coming to us with fever, first thing is check for the vitals, then look for congested eyes, throat is congested. Is there any rash? Is patient is having some sort of pallor, any jaundice, any lymphadenopathy, any hepatosplenomegaly, any tenderness anywhere? So there are basic things to be looked into any patient who is coming to us for the first time with fever. So what we are looking for, what we want to diagnose in a patient who is coming with a very short history of fever, let's say we are considering only infectious illnesses as of now. So this can be viral fever. During change of season, we see a lot of patients coming with a normal viral fever. Virus is a generic term. Dengue is also virus. COVID is also virus, but undifferentiated viral fever, I would say. The name of that virus we don't know. Either we don't have a serology, or we are not ordering to identify which kind of virus that is. So that is viral fever. So dengue fever, maybe malaria. Dengue fever, we all know, this is like the whole country is going through the endemic of this dengue fever as of now. Malaria. Few areas in our country, they do have attacks of this fever, malaria fever, during the rainy season, and sometimes during other seasons also, but the peak is also during this season. Enteric fever, typhoid fever, chikungunya. In some part of our Haryana, the whole of the village, town, every human in every home is suffering from this fever. I know a few areas in the Yamunanagar where this is a small area in Haryana, where almost every family is some of their member is suffering from chikungunya as of now. Scrub typhus, leptospirosis, or maybe sepsis. Anything is possible in a patient who is coming to us of a fever duration of maybe 1 day, 2 day, or 3 day, or 4 days of duration. So this we have discussed in the last time also. I discussed this thing on 8th of August. Syndromic approach to acute tropical fever. How do we approach? So fever can be acute undifferentiated fever, just to revise. And what is acute undifferentiated febrile illness? Any patient who is coming to us with febrile illness of less than 14 days of duration with a higher degree temperature more than 100 degrees or 101 degrees, exactly to be very precise, more than 100.4 degrees. So how should we approach? We should try to rule out, if this is an infection is to be ruled out, then malaria, dengue, leptospirosis, scrub typhus, and enteric fever, or maybe very recently we know a very notorious thing, Nipah virus. So we'll discuss something about Nipah virus also. So fever with rash and thrombocytopenia. Dengue is the first thing, rickettsial infections, maybe scrub typhus, and maybe leptospirosis, maybe malaria. These are very common during this time of season. Fever with ARDS, we all know, all complicated, all serious kind of infections can lead to ARDS, maybe scrub typhus, falciparum, maybe influenza, H1N1, COVID, hantavirus, melioidosis, or Nipah virus. All these can lead to ARDS. Febrile encephalopathy, again, cerebral malaria, which is a very dangerous kind of malaria to have in a ward or in ICU. Typhoid encephalopathy, scrub typhus per se, any sort of bacterial sepsis can lead to. Japanese encephalitis, herpes, enteroviruses, they all can lead to encephalopathies. Fever with multi-organ dysfunction, we all know any serious form of infection sepsis can lead to MODS, multiple organ dysfunction syndrome. And very notorious things are, again, sepsis, UTI, urosepsis, pneumonia, sepsis, GI leading to sepsis, GI infections leading to sepsis, and ultimately multiple organ dysfunction syndromes. How do we treat all these empirically? Like, patient is coming to us on the day, maybe day 1, day 2, and we suspect sepsis, and how do we treat? Basic hematology workup is to be done, basic biochemistry work is to be done, and malaria, dengue rapid test is to be done. We know all these tests are usually available in 1, 2 hours, 3 hours in most of the labs. So we have some results. Till the time, we do aggressive fluid resuscitation. And if we suspect that area is not having many dengue cases or maybe many malaria cases, then we can start with the first dose of antibiotic. And which kind of antibiotics to be given if patient is not in shock, patient is not requiring anatropes, is not ventilated, definitely we can go with ceftriaxone and doxycycline pretty safely. So this we have discussed, and this we have revised. This is the approach of approach to a patient who is coming to us with a febrile illness of short duration. Now, a few words regarding dengue fever, which is like is creating havoc. It creates problem every year, and story continues. The causative organism is like it's a flavivirus. Dengue virus have a 4, Den 1, Den 2, Den 3, Den 4 serotypes, and Aedes mosquito is the reason which bites and leads to introduction of this virus into human beings and ultimately causing this dengue fever. Incubation period is 4 to 10 days, and we all know the pathogenesis is a cross-reactivity. There's basically amplified cascade of cytokines and complement activations and ultimately dysfunction. A little, why I put this very busy slide is like classification of dengue fever. We all know there was a classification in 1997. 1997 classification was a classical dengue fever, dengue hemorrhagic fever, and dengue shock syndrome. There was a problem with this classification because there was no clear-cut demarcation of a patients coming with dengue fever or dengue hemorrhagic fever or dengue shock syndrome. So clinicians were very confused when to label dengue hemorrhagic fever, when to label dengue shock syndrome, and a patient who is coming with a like seemingly normal fever turns out to be a dengue hemorrhagic fever. So in 2009, the criteria was changed by WHO, and now there is a probable dengue. But the probable dengue is like patient is like we know that dengue is endemic at present in our area, and we are like having some epidemic, and that dengue is creating havoc, and patient is coming with a febrile illness. Patient is coming with nausea, vomiting, some rashes there. Tourniquet test is positive. There is a mild leukopenia in CBC. Even if we don't have a dengue test with us at that point of time, we can consider this possibly a probable dengue. So that is dengue fever. And what are the warning signs of dengue fever? This is, I'm again stressing this, we need to tell each and every patient better if we can write it on their prescription slip on every patient. पेट में जोर से दर्द, abdominal pain, epigastric pain, right upper quadrant pain, rather I would say, persistent vomiting. If there is any mucosal bleed, if there is any lethargy or restlessness, if there is a liver enlargement, if we can feel, liver enlargement we can feel, they cannot feel. But what we practically tell, what I practically tell, or what practically is told to patient, if there is a abdominal pain, excessive vomiting, if you see any bleeding, except menses, if you find patient is having blackout, cold sweats, then this is a very serious form of dengue going on. Please do not sit at home. If home care was advised, please reach emergency straight away. And that patient needs in hospital care. So those warning signs are very, very important. That's why I put this slide. So, and what are the criteria for severe dengue? These warning signs ultimately leading to dengue shock syndrome and fall in BP, and there is a capillary leak leading to edema, accumulation of fluid in the pleural cavity, abdominal cavity, ultimately ascites and everything. And that is like serious thing. If we are able to, if we have a time to get the labs and we have a labs with us, then AST, ALT elevations more than 1000 is a serious thing. So it's not a low platelet count, which is a seriousness. I always tell my patients, I always teach my JRs and my newer doctors who are coming to us in hospitals, please stop looking for platelets only. As a PCV or hematocrit, which is more severe marker, which is a marker of severity. Increasing hematocrit more than like 15% in a day is a dangerous sign. If we have an increase in hematocrit, rising hematocrit, even if platelet count is stable or if platelet count is falling, not falling, hardly matters. And patient is having some cold sweats, some abdominal discomfort, ghabrat for that matter. Nothing else, only ghabrat. That patient is having impending dengue shock syndrome. Please do take care of that patient. He needs IV fluids, aggressive fluid management, aggressive management in medical ICU, and patient will be salvaged. If we lose that particular time and we are not able to identify that thing in time, maybe in a 2 hours or 3 hours delay can lead to havoc. So any bleeding, we know severe bleeding, patient is having GI bleed. That is definitely serious dengue. So platelet count at that point of time is important because the patient is bleeding. What we actually teach patients, what we tell our patients is it's not platelet कम होने से bleeding नहीं होती. प्लेटलेट कम होने से ब्लीडिंग नहीं होती. ब्लीडिंग हो जाए और प्लेटलेट कम हो तो ब्लीडिंग रुकती नहीं है. So there is a hell lot of difference in the statement. So please don't be afraid of thrombocytopenia if patient is not bleeding. So only thing is, like we have seen, still there is a lack of awareness, or there is like our colleagues are not able to handle pressure. There are so many patients coming to us who has been transfused STAP, single donor apheretic platelet, or maybe random donor platelets at a platelet count of 50,000, 60,000, 70,000 without any bleeding. But their platelet is low, and that is not the way of treating dengue. So it's not like people are not knowing. Most of the doctors know it very well, but still there is maybe because of pressure, maybe because of like we are feeling a lot of heat from the patient. The people are standing, doctor, his platelet is falling. Why don't you transfuse? And in that flow, and doctors also agrees, transfuse. At that time, we really need to know what is wrong, what is right, and we need to counsel patient if patient is not bleeding. If patient is not bleeding, there is no rationale of platelet transfusion in dengue, unless until platelet actually falls below 10,000. If patient is febrile, still febrile, and platelet count is less than 20,000, that becomes an indication for prophylactic platelet transfusion to seal any unseen bleeding. Few words about Nipah virus. Nipah virus, we know that we are listening in the news and we are reading in the newspapers, and like we are saying everywhere that in Kerala there is a Nipah virus attack is going on, and Nipah virus is a zoonotic. So I thought of putting few words about Nipah virus. Nipah virus is zoonotic. Basically, it's from a fruit bats or pigs, and they lead to contamination of food, and that food can lead to infection of human beings. And there is a direct human-to-human transmission possible. That's why there is a role of isolation. And so, which kind of food we should avoid or we should be aware of? It's basically dates. It's very common to the bats are there, and bats do infect dates with their saliva and urine. And if you consume that raw dates which have been contaminated by fruit bats, there is a chances that we can be infected by Nipah virus. And Nipah virus incubation period is 14 days, and that can cause a florid of symptoms, including from very basic asymptomatic infection to ARDS and fetal encephalitis. Presentation is like a normal any virus, fever, sore throat, headache, myalgia, vomiting, but very rapidly this can go to like dizziness, drowsiness, conscious level, respiratory rate, and flow rate ARDS picture, seizures. This can happen in a span of maybe 1 to 2 days only. So it's a very rapidly evolving kind of illness. Most patients who suffer from acute encephalitis, they also recover. But up to 20% can have a residual neurological deficiency, like seizure disorder or personality changes. Case fatality rate is 40 to 75%. It's a very serious kind of illness. There is no treatment, and only primary treatment is supportive care, and prevention is always better than cure in this case. So this is all for today. So now we can take some questions. First question is from Anang Mohan Basu sir, and he's saying, can a healthy young patient can take Flemiclav 625 when he's fasting for 40 hours? Why a healthy patient, sir, will need antibiotic for that matter? If a person is healthy, why should he be on antibiotics? I don't find any reason for giving an antibiotic. If the question is like he is fasting and he's having some infection where you feel that there is a need of amoxiclav, definitely they can take. There is nothing like a fasting person cannot take it. So second question is, and Anand sir is also saying thank you. Thank you so much, sir. Thank you. And there's another question from Dr. Vinay Desai, and saying, what to do if there is a continuous fever not touching normal in spite of full dose of paracetamol? That is a very, very important question. Thank you for asking this question, sir. This is the most common thing which we see in our OPDs during dengue season, or when we are afraid of bleeding and thrombocytopenias and platelet dysfunction. We always say, please avoid NSAIDs. We say, don't take any sort of NSAID. Just take paracetamol for your symptoms of fever, headache, body aches. And the patient is saying, sir, my fever is 104 and it's not going even 103, even after taking paracetamol 650 milligram. Even if I've taken 2 paracetamol tablets, the fever is not touching even 102, 103. What to do then? So then the answer is, sir, cold sponging. If we can effectively rule out dengue, if we can, the CAR test is negative and we don't suspect based on other clinical signs and symptoms he is suffering from dengue, then we can give other NSAIDs to decrease the temperature at that time. Cold sponging is very, very important, and we have discussed about cold sponging in one of the sessions. Cold sponging is not with the ice cold water; it's with a normal temperature water, or rather lukewarm water. Dr. Santosh sir is asking, is neutropenic fever better medicine choice? So neutropenic fever, why there is a neutropenia? Try to look into it. If there is a chemotherapy induced, or maybe there is some bone marrow involvement because of some sort of carcinomas, then depends. How much is the neutropenia? How much is the ANC? Absolute neutrophil count less than 1500 is neutropenia. And if it is less than 100, less than 1000 is a moderate, and less than 500 is a severe neutropenia. If patient is in shock along with neutropenia, or patient is having severe neutropenia, then IV injectable antibiotics are the choice, and ceftazidime is usually stands the point. And if you suspect any gram-positive, then definitely we need to give gram-positive coverage. And if you suspect some sort of fungal infection, definitely we need to give a fungal prophylaxis also. Then there is a question, sir, what is this new drug Synriam? Synriam is not a new drug, sir. It's been a couple of years, and it's for a very nice drug for the treatment of Plasmodium vivax malaria. And one tablet daily is to be given for 3 days. And can we use this in children? Sir, I'm not aware of regarding children, but more than 14 years, definitely we can give. So next, sir, Dr. Vijay Tejru sir is asking role of injection artesunate in case of dengue fever. No, sir, there is no role of artesunate in dengue fever. There is a role of artesunate in malaria, as we all know. If somebody is confused, that patient can have an add-on dengue fever and add-on malaria in a case of dengue fever, then one can use artesunate. Otherwise, there is no rationale of using artesunate in dengue fever. So Anemon sir again is asking, the otherwise healthy person is having acute respiratory infections and wants to continue its fasting. As in Mumbai, we have a Ganpati festival, and that's a very, very happening time, sir, in Mumbai. And so even an upper respiratory infection usually is because of some viruses. We usually don't suggest any antibiotics to begin with. And if there is like, we can see the throat, and if there is a pustular tonsillitis, follicular tonsillitis is there, then definitely amoxiclav is better. Or if there is some Krebs, or if we suspect some LRTI, then definitely, or maybe some sinusitis, bacterial sinusitis, we can give amoxiclav. Otherwise, there is no need to give amoxiclav. So another question is from Manoj sir. In dengue, few administer antibiotics IV, even though clinically kid is not sick. I have seen few pedia docs give piptaz and amikacin. Sir, if I'm sorry, but there is no rationale of using antibiotics in pure dengue patients. If we have a dengue patients and we have add-on secondary bacterial infection in those patients, definitely we can use antibiotic based on need, based on focus of infection, maybe LRTI, UTI, GI infections or something. In majority of cases, even if patient is having diarrhea, diarrhea is not because of bacteria, even probiotics will work better. And in 1 to 2 days, diarrhea settles down. There is no need of antibiotics. Patient continue to have fever. This is like typical of dengue. Up to 5 days, there can be high grade fever. Usually 3 to 7 days is the time of time duration of fever. So if a fever goes beyond 7 days, then we should think of any add-on second infection, and we can use antibiotics. Kishan sir is asking, sir, if dengue comes positive, so any role of IV fluid? Definitely, sir. If patient is having dengue fever, the only role is of fluids, be it oral or IV. If patient can take oral fluids, it's stable, vitals are okay, is not feeling dizzy, there is no warning sign we've discussed, oral fluids only. There is no rationale of giving IV fluids in a healthy, normal, uncomplicated dengue. If patient is sick, showing any sort of warning symptoms, there is a huge role of IV fluids. IV fluid to be given, sir. And then Sanjay Shirwa sir पूछते हैं, most of the neutrophil high in acute fever in CBC, is it normal or something going? No, sir. If there is a bacterial infection, neutrophil count is high. In dengue or malaria, neutrophil count is not high. Usually, it's not high. So the things are like. Next question is Dr. Sujit Kase is asking, we can start intravenous antibiotics in OPD in 3-4 days fever? We cannot start intravenous antibiotic in OPD in 3-4 days fever. Okay, probably Dr. Sujit Saab is trying to ask, should we start IV antibiotics, or if patient is coming to us and the 3 days fever, maybe he came on the first day and second day and third day and fourth day, every day says my fever is not going. So let's try to fix out what is causing his fever or her fever. In many times, we are not able to pinpoint, and we have effectively ruled out there is no dengue. Why not to start with the oral antibiotics rather than IV antibiotics? If patient is sick, patient is getting sick, or is not able to take, he is having lots of nausea, vomiting, or maybe GI symptoms, or we feel that patient is going into sepsis, then definitely, or if we can demonstrate there is a rising, some parameters are deteriorating, on a biochemical parameters are deteriorating, definitely we can go for intravenous antibiotics, even on the day 1, if patient is sick. But otherwise, in a routine cases, the patient fever is not responding in 3-4 days, there is, I think we should wait for at least 5 to 7 days before starting IV antibiotics. Dr. Vikas sir is asking, what should be choice of antibiotics for a 3-day fever? Sir, again, what is causing 3-day fever is very, very important. And if we say a fever is going, in many of cases, if dengue is going on, there is no rationale of any antibiotic. So there is no need of any antibiotic. Fever can last for maybe 5 days. This will settle. If we suspect any bacterial infection and we nothing is spreading at that point of time in that locality, then we can think of antibiotics, and especially if blood reports is also suggestive of, if your C-reactive protein is high, is very high rather, we can start with with oral or IV antibiotics. Kishan sir, I'm confused in IgM, IgG dengue test, please? Oh, thank you so much for asking this question, sir. Thank you so much. And I'm very glad that somebody has asked this question, otherwise I would have forgotten. Sir, dengue test, how we diagnose dengue? Dengue is diagnosed by a CAR test or maybe by ELISA, and there are three confusing terms: NS1, IgM, and IgG. NS1 is antigen. Antigen is of virus. So virus per se is they produces antigen. So one of the component of virus is detected. So this is earliest to be detected. How early we can detect NS1 antigen in a patient coming with a febrile illness is 6 hours. After 6 hours, if we order a test, patient is coming to us within 1 to 2 hours, please do not order any test. Wait, maybe for the next day, and we can order a dengue test. If it comes after 6 hours, we can ask for NS1 antigen. NS1 antigen can be detected in the first 6 hours. IgM is an antibody response of that particular patient to dengue fever. IgG is again an antibody response of that particular patient to fever. It's not a part of dengue virus per se. So in how many days antibodies will be formed? At least 4 days. After 4 days, antibody formation is there, and they usually peaks around 7 days, 8 days, and we can easily detect the IgM antibodies. So IgM antibodies, as we all know, suggest or depict acute infection. IgG antibodies depicts chronic or past infection. If somebody is having IgG positive, that doesn't mean patient is currently having dengue. So we cannot attribute current febrile illness as a dengue fever if NS1 and IgM is negative and only IgG is positive. So why to add up this kind of confusion? Why at all this IgG test is being done? Sir, as we all know, why the IgG, any past infection of dengue, like if somebody has a dengue in the last year, or last year or 3 years ago, and now having dengue fever again, so chances of severe dengue fever is very high in that particular patient. To know the chances of severity, possible severity in a particular patient, we do IgG test. IgG test has no role in diagnosing acute dengue fever, sir. So please stop. One can ignore it. Ignore looking at IgG for diagnosing dengue fever. Look at NS1 and IgM only. I hope I could clear this doubt. Ashok Sharma ji asking, sir, like Ayurveda predicts, is some medicine to raise platelet count? There is no medicine to raise platelet count, sir. There are few medicines to raise platelet count. Why platelet is falling in dengue is altogether different things. Ayurveda is all saying, what Ayurveda is saying is there is like some caripil, something to raise platelet count. How does this work? Does it really work? So I have a very strong notion, a big no. पपीते का पत्ता, गिलोय बकरी का दूध, नारियल पानी. कीवी पपीते का पत्ता, गिलोय बकरी का दूध, नारियल पानी. Antibiotics, multivitamins, they are not going to take care of dengue in any way. Dengue will be taken care by human body's self-response. We have antibodies. We have immune system to fight with the dengue fever. There is no way these things can actually alter our system to fight with dengue. So, sir, there is no Ayurvedic medicine per se, I would say, which can actually fight with dengue. So there is no rationale, rather, I would say, to prescribe this kind of drugs. Dr. Vikas is asking, dose injection amikacin role in fever? No, sir. There is amikacin role is in few very limited cases and have to be very cautious. An nephrotoxic drug. So dose depends on, like in adult patients, we give 750 milligrams once a day. But have to be very cautious while giving amikacin because the patient is already having fluid depletion in a fever. They are fluid deprived and they have a very high chances of nephrotoxicity. Any role of Tamiflu in 3-day fever? No, sir. Straight away, no. Empirically, no. If there is epidemic going on, of H1N1, then till the time we get a report from H1N1, we can give. If we suspect there is a respiratory symptoms are going on and patient is high risk, we can give empirically. Sanjay Siroya sir pushing, is it okay to give ceftriaxone IV without diluting 100 ml? And sir, this causes very severe thrombophlebitis. That's why we cannot give. It causes very severe thrombophlebitis. So there is nothing like we cannot give, but it's going to be very painful for the patient. Sir, in dengue, Kishan sir is asking, in dengue patients, positive patients, SGPT is slightly elevated. So is it serious, or we can manage it in clinic, sir? As in one of my slides, I've shown that AST, ALT, SGOT, SGPT level is elevated, definitely elevated in all dengue patients. If it is more than 1,000, then you are not supposed to manage patient at clinic. If it is less than 1,000 and patient is clinically stable, we can manage it at clinic. There is no rationale of any other extra treatment to be given for SGOT. It's a self-limiting, we'll cover back. We'll revert back. Ferguson sir is asking simple rule of fever and diabetic management, take home masses, please. So there is no simple rule of managing fever in diabetic in diabetic patients. Rather, diabetic patients also like a patient like a non-diabetic patient for a fever that matter, with a slightly more risk of having more severe infections. So we need to find out. We need to stratify what kind of infection is going on. But we suspect. Are we suspecting viral, protozoal, bacterial, fungal, which kind of infection we are suspecting, and that actually going to decide the type of treatment we're going to give. Avinash sir is asking, sir, Carica papaya is effective in dengue fever? No, sir. No, it's not. But I feel it's not. But not I feel. There is no proof that this can work. There is no way that this can lead to destruction of virus, and ultimately it's a basically cytokine storm which is killing. It's not thrombocytopenia which is killing. Please understand, it's not low platelet count which is serious in dengue. There is no rationale of giving platelet in dengue, sir. Platelet is just a byproduct. Low platelet count is just a byproduct in dengue. It's not a complicated thing. It's not a marker of complication in dengue, sir. So there is like nothing. We just raise platelet count and patient will be okay. No, it's not going to work. So Carica papaya, for that matter, it's in market for more than 10 years, I think now, and never used in any patients. Never type. Ashwini sir is asking leukopenia, LRTA, or dysentery. Your comment on coronavirus or its variant. All types here. Corona can have all type of things. It can have so viral illness can lead to leukopenia. It can have definitely lower respiratory infection. Pneumonia is a treated form of COVID we have seen. It can have a GI symptoms. Definitely, it can have a GI symptoms. All type of symptoms on coronavirus can give. So as of now, there is no antiviral is being prescribed in our guidelines for coronavirus. In the second wave, we have given lots of antiviral for this COVID, but now it's only supportive treatment. Ajay Kumar is asking, Plarica as well as Famiclav, both are equal in dengue or typhoid fever? It is, I'm not aware. What is Plarica? I guess this is some brand name. I'm not aware of. So, Shobit Agnihotri sir, NS1 positive, IgM, IgG, both negative, 6 days duration, what to do? So, it's a dengue fever, sir. We need to treat like a dengue fever. No confusion. Either NS1 positive or IgM positive. Any of them positive is an acute dengue fever. We need to treat like a dengue fever, sir. So, we really need to say, really very thankful to all my dear friends who have asked so many questions, and there are few more comments. Vinayak Sarmaji sir is saying good evening sir, good evening to you too, and VM brother sir is saying good evening to Kala sir. Kala sir, good evening. And guidelines for LASIK, Manish Change साहब पूछ रहे हैं, guidelines for LASIK along with IV fluid and dengue capillary lock syndrome. There is no rationale of LASIK along with IV fluid and dengue fever. We need to manage capillary leak syndrome, massive capillary leak syndrome leading to respiratory distress very cautiously, but we need to stop IV fluid if something like that is happening. There is no rationale of giving IV fluid and plus furosemide along with. So fever with NS1, Gurchan sir is asking fever with NS1, TLC 3100, neutrophil 78%, platelet 1,29,000, feeling weak for 3 days. How to proceed? Conservative management. It's a viral fever. It's going to lead to lots of weakness, lots of fluid and rest. Paracetamol or Swiss. That is the only way of treating it. And keep monitoring platelet count, sir. Platelet will fall from day 3 to day 7 at least. Mostly, patient will start recovering from day 8 onwards. So sir is asking, next comment is NS1 is negative. So then keep monitoring. Maybe a virus other than dengue fever. Keep monitoring. Platelet count is low in any of the viral fever. Many fevers can lead to low platelet count. Manish Jangi when to use Lasix in dengue fever, there is no rationale of Lasix per se, but to treat with extreme respiratory distress in a patient with the extreme capillary leak syndrome, and patient is not able to breathe, we can use a low dose of diuretics. Otherwise, there is no role of Lasix. Shajana Heather Ali Saab पूछें, what does IgG develops? When does IgG develop after first time dengue fever? Thanks, sir. After 1 month, sir. It's almost after 1 month. IgG develops. So we have some more questions. Asma Qazi Saab पूछ रहे हैं, can't we let lifelong immunity after first infection of dengue? Any chances of vaccine for dengue? Dengvaxia is a vaccine, sir, which is being now is in trial phase in India, and many centers being given. So Dengvaxia is basically to be given a patient who has already suffered from dengue fever, and now they are giving it. And let's see the actual real-time efficacy of this drug and this vaccine. If it is proven good, that's going to be like a game changer for dengue fever. So because the most of the casualties do happen in the second attack of dengue fever rather than the first attack. So the answer of this thing, can't we have a lifelong immunity after first dengue? We do have a lifelong immunity, sir, to a particular serotype, not to different serotype. We have at least 4 defined serotype. And we know there is a 5th serotype also for which there is no test available. So even an NS1 or IgM test is like what we do CAR test, they detect dengue in almost 96% of cases, and there is a 4% pseudo-negative or false negative report. So Manoj sir is asking, 2 days fever with the dengue serology negative, what kind of fever we should consider with falling platelets? Dengue serology negative, please repeat dengue test, sir. This is quite possible, and that is very important, and we can check for like how much thrombocytopenia is significant, at least less than 1 lakh. Anything more than 1 lakh, we don't bother, and nobody need to bother about thrombocytopenia more than 1 lakh, like up to 1 lakh to 1.5 lakh hardly matters. So if it really falls below 1 lakh, it's definitely we should look for other causes also, and along with dengue also. Sometimes I have just discussed there are 4% cases who have a DEN5 and for which there is no test even available. MPV in CBC, mean platelet volume in CBC, sir. There was a lot of hue and cry about MPV in management of dengue, but practically nothing, sir. No role as of now. Sanjay Saroy sir is asking CBC repeat time in dengue fever daily, sir. This is to be repeated daily, and if platelet count is less than 50,000, twice daily. We need to check platelet in PCV twice daily if the platelet count is less than 50,000. So, sir, Imran Malik sir पूछ रहे, if not antibiotic, then what we use in dengue fever, sir? Pani. What is to be given, either oral or IV? That is the thing to be used in dengue fever. No antibiotics. Antibiotic, for that matter, is for bacterial infection, not for viral infections. It's a viral infection, so we don't use antibiotic in this case, unless until there is a secondary bacterial infection going on. So that is not to be used. So so Anil Chaudhary Sahib is asking, is there any roles of steroids? If yes, what steroids and when to use? There is no role of steroids, sir, in management of dengue fever, not at all. Not at all. So we are not using any type of steroids in the management of dengue fevers. So dengue fever is a self-limiting illness, and again, sir, what mistake we are doing in the management is we are just using platelets. No, sir, platelet is not a serious marker of seriousness. Platelet just is a co-bearer in the dengue. Look for PCV, look for other markers, look for clinical signs and symptoms. platelet will start improving once dengue is being taken care of in 7 to 8 days of its total course of symptomatology, rather, when it starts showing the symptoms. Is NSAID lead to thrombocytopenia? Sir, NSAID lead to platelet dysfunction. That lead to not exactly thrombocytopenia, but platelet dysfunction. So whatsoever platelet we do have, their dysfunction, so the chances of bleeding increases. That's why we say please avoid NSAIDs. So if we don't have any question, Pratik, can we conclude?
Yes, sir. I think thank you very much, Dr. Suneet, because you have taken a vast and very comprehensive sessions, and at the same time you have taken all the questions which has come on the way. And with this, we thank Dr. Suneet for taking the second session in our ongoing session of tropical fever under Diabetes Essential. We have another 3 sessions left, in which we will be one of the questions which has been asked, that how to manage a fever in a diabetic patient. We have 2 diabetic related sessions coming in. One is endocrine fever, as well as the second is diabetes and fever, which will be taken by Dr. Sanjay Kalra and maybe one by Dr. Nitin Kapoor, who is the HOD of the endocrinology department in CMC Valley. Another session related to the tropical fever will be related to today's topic, which is 7 days fever, which is coming up. The patient is coming with 7-day fever, which will be taken care by Dr. Paritosh Baghel, which will be a sequential session of this, maybe on 1st of October. With this, I sincerely thank Dr. Suneet for being with us and happily taking all the sessions as well as all the question answers during this topical series in our diabetes session. Thank you very much, sir. Good night and Jai Hind, sir.
Thank you, sir. Thank you. Jai Hind, sir.
Jai Hind.